give you some general principles about how to take wherever you're at in terms of psychological assessment and inclusion of that in your practice, whether it just be routine screening of depression or suicide, things like the PHQ, or something more sophisticated than that, and try to, in a couple of ways, I'm going to give you some general principles for doing that, and then hopefully spend about the second half of our time today really just discussing and getting into the practical take-homes. Just a reminder, is everybody on mute here? I think I'm getting some feedback. So I did bring a case presentation to give you an idea of some of the principles in action that I'll be talking about today, but I'm more than happy and would prefer if people have specific questions or case consults, we can do that live today, and I'd be happy to consult on that. So objectives sent out to you, we'll go through these. So the first thing I want to do is make a distinction between testing and assessment. What I'm going to be talking about today is psychological assessment and how we can integrate that into clinical decision making, whether it be behavioral clinical decision making if you're in the mental health field or allied mental health field, or medical decision making. We all use testing regardless of our specialty, but I think we can all agree that there's a difference between testing and what gets done with the test scores and the test data. And that's really where I would like to focus. And I want to point this out because I think there's a push in evidence-based medicine, and it has, it's good intended, but it has some deleterious side effects, which is to skip the assessment process and just focus on testing. We want to come up with guidelines, cutoffs, strict rules, rigid rules that allow us to go from testing to decision making without much room for adjustment based on the individual history, based on other data, or based on clinical impressions. And so I think that both approaches can be merged. I think that you can do that in an evidence-based way. I think you can take guidelines based on research data and empirical data and integrate them and make changes to them and adapt them in a way that's scientifically sound to enhance the care that you're providing. So for those of you who are not specifically in the mental health field or allied mental health fields, just my small pitch for why thinking about psychological assessment, testing, and measurement in a more rigorous way would be beneficial to you. A couple of points. Number one is psychological assessment data can be extremely meaningful and useful for filling out the picture of diagnosis, prognosis, and treatment planning. If you look at the leading causes of death and disability, basically all of them either have a minor or substantial behavioral component to them. And so if you're not gathering this type of data, in my opinion, just missing part of the clinical picture of variables that are dominant impacting patient outcomes. And a lot of times, a lot of the measures, psychosocial measures, symptom measures, they are some of the more important outcomes to be measuring because that's what people care about. People care about quality of life, general well-being, and less about some of the more technical outcomes that we in the sciences look at when we're doing RCTs or more mechanistic research. The other point in on the side of psychological assessment, especially with standardized testing, use of self-report measures or other types of measures, is that you can gather a lot of information with those types of tools in a small amount of time. So in my work, on every day, I work with kids who have been exposed to traumatic events, and common question is, are they traumatized? And so from a diagnostic perspective, the question is really, do they meet criteria for PTSD or something else? And PTSD is a very complicated diagnosis. There are a lot of symptoms of PTSD that overlap with other diagnoses, and it's very hard to do that. And If I were to just spend time informally talking with the child, his or her family, and just trying to gather all of that symptoms, there's about 20 symptoms of PTSD. I could spend all day and not really know. Whereas I could administer some measures that hit on all 20 of those points. I could get that information from the patient, their caregiver, and any other sources I wanted to. And it would be clean data, it would be standardized, and it would be much, much quicker than me just sort of talking my way through it with families. And the final point I will make is that a lot of times this sort of behavioral psychological data, especially for those of you that are outside the mental health field, can contextualize responses to interventions that are aberrant, can contextualize presentations that don't fit your common practice, or that really aren't, that are just quizzical or causing some sort of hesitation. You know, a lot of times the psychosocial component of health gets missed, and we're getting outcomes that are surprising to us or confusing to us. Gathering a little bit more data on that end can really help inform where to go next. So just some examples. So I hope that most of the providers here are familiar with the PHQ-9. It's probably about the most well-disseminated measure of depressive symptoms. Most hospital systems use this routinely or require their providers, at least at first patient visits or new patient evaluations, to administer this, regardless of their specialty. It's 9 questions and their depressive symptoms. And here's some common interpretations of the PHQ. And so the PHQ was originally designed as a screening tool to identify individuals at risk for depression. It's not a diagnostic tool. It's not very comprehensive. It has about 9 questions on a Likert scale. And there are some published cutoff scores that are based on field trial data from the DSM-4, and those have been updated in recent years somewhat, but there's a number of ways of interpreting this particular measure. And so I mentioned before, I'm trying to push you wherever you're at along the spectrum of from just testing only to assessment, which is this idea of taking the scores and the evidence that score from the empirical work, the scores tell us. And just a reminder, if everybody could mute, please. I'm getting a little bit of feedback here. The goal with this testing, back to my point here, is that what we're trying to do is go from, okay, what does the science tell us that this score means? And then what we're trying to do is take that and integrate that with what we know about the patient individual and adjust our confidence intervals for what that score means. And more importantly than that, we're hoping to gather information that's clinically useful, not just, okay, well, the relative risk for this condition is an odds ratio of X, Y, or Z. We're really wanting to be able to say, make predictions about their diagnoses, and more importantly, wanting to make predictions about what's best for them as far as intervention in the long term. And so the way that most testing measures, psychological or biophysiological, are validated, they're not validated with that level of granularity. They're usually developed and administered to have some reliability and consistency, and then they're linked by correlations to an important outcome, and then we start using them. And so the idea being is that we can use other information to help fill out the picture of what those scores give us. And so here's some thoughts. You know, you could just focus on the cutoff score. That's probably the most minimal interpretation. That's the most minimal assessment to be done, is take a patient's score and compare it to some established clinical cutoff from the research and tell them, okay, well, this suggests that you're going through a depressive episode or you're at risk for one. A more granular, more well-informed and responsive way of looking at it, you might take a look at their individual responses, if those scores are elevated or not. And you might find that the scores were not elevated, but the patient had lots of endorsements at a minimal level on lots of symptoms. That's quite different than scores that are elevated primarily from 1 or 2 symptoms. And in that case, they might not meet full criteria for the diagnosis, but they might be still struggling in ways that they could benefit from particular interventions. Let's move on here. Okay, so I got sort of 3 general factors or principles to kind of consider that my hope is in designing these that they can be applied widely to different settings and used to take you from a rule-based, we administer this measure, if the score is above cutoff, we say X, if the score is below cutoff, we say Y, and take that rule system and make it a little bit more personalized and get there with a little bit more fidelity. So 3 factors to kind of consider. I think about this, I'm primarily a researcher, so I think about an assessment in the context of a patient interaction, just like I think about fidelity in research. And so there's a number of things that determine the quality of the data. And so the first one is probably the most important one that I'll focus on is the interpersonal context. So I'll just give a quick story. I saw my PCP probably about 4 weeks ago, about a month ago, and I was administered that PHQ by an MA, and the interaction went a little bit like this. I sat in the waiting room, there are social distancing measures. I got called up, I got asked some screening questions about smoking and drinking at the front desk and in the lobby with other people. I responded to those. I got pulled into a hallway. I was asked verbally the PHQ questions in the hallway by a different person, and then I was shuffled into my visit with my doc, and she went over all of those scores and all of those assessments with me. And just a couple of points about that. There's some pragmatics to that. You know, they're trying to be respectful of my time and try to get that information in as efficient way as possible. But I think that as far as gathering quality data about potentially sensitive information, the interpersonal context is not quite there. And what we know is that these demand characteristics, does the patient feel comfortable reporting to the person that is there, have a marked impact on what they say. And there's research on this in the psychological assessment literature. You give somebody a pencil and paper questionnaire, you give them time in a private room, you'll get different scores than if you had that person have those items read to by a stranger. And so the reality is the way in which it's delivered and who delivers it makes a big impact. And what we're shooting for here is we want to have some establishing operation for trust. We want to be having this measure delivered by somebody that the person knows in a place that's private and in a place that is conducive to them being able to deliver you sensitive information. Okay. Second point about that, the interpersonal context, is that if you're wanting to get reliable data, people have to feel like it's meaningful and useful for them. It's not just a rubber stamp that they're completing just like the rest of the paperwork that they completed. They have to feel like this is an important piece of information that's critical to their care. And so as best as we can do to say, hey, here's a screener for suicide or depression or substance use, what we find is that those are both extremely important factors in patients' health outcomes just as much as blood lipids or body weight. And so we here in this office make a point of getting that from all of our patients. Just a rationale like that goes a long way for somebody to help them be a little bit more willing to give you quality data. And it doesn't take a long time to do that. But if we don't do that, we run the risk of people responding to it just like they do the rest of the paperwork. And I don't know about y'all's clinic, but a lot of times in my clinic, when I give questionnaires and background forms, I get a lot of skipped answers. People rush through those things, and so we want to connect a rationale that's motivating for them to really give the truest responses they can to those items. So that's the interpersonal context. The second factor that really impacts the quality of the data and the meaningfulness of the data and the utility of the data that we gather from psychological assessment measures is the conditions, and this is the testing conditions rather, and this is no different than any other testing domain outside of psychology. So if I were going to get a lipid panel, which I did after my most recent PCP visit, it would probably be different if I gave it on a typical day like today versus I ran a half marathon before and completed and then gave blood and got the test. Those would be two different. Those would lead to two different results, and we might not consider the latter result super valid or useful for general health purposes. And so what we want to do is strive to administer it in a way that, number one, is most similar to the way in which the measure was validated. And so if you in your practice, in your clinic, are administering any self-report measures for adults or children that have some sort of Likert style response where they read an item and circle a response from least to most problematic, the way that those measures are administered, and I know this because I've done this research, is we give those to kids, we let them complete it, we give them the instructions, we let them complete it in privacy in a quiet, distraction-free area, okay? In very rare cases, except for young children or adults with special needs, are items read? Are they separated and given out of order? And so the more that we make those things, and I understand that we have to take what's in the research and apply it the best we can. It's a striving for principle. Can't recreate everything, but we just have to recognize the more that we diverge from those standardized test conditions, the more likely that error is creeping into our data, the more opportunities for distraction, low effort, confusion, or these interpersonal demand characteristics influencing the test quality data. Okay, pretty common example of that is in a clinic I used to work at. We would give again the PHQ, and one of the symptoms of depression is poor concentration. You're feeling so depressed and so low energy that you find difficulty persisting through difficult intellectual tasks, like if you're a desk jockey and you find yourself daydreaming and that sort of thing. And we had one clinician that she would administer this to teenagers and read them, and she would tell, when it came to that item, she would say, well, not your ADHD symptoms though. She would give an additional instruction, because some kids with ADHD would rate that high. I get distracted a lot. I find it hard to concentrate. And while the spirit of that instruction is to remain true to what the assessment measure is trying to gather, it's a complete violation of the test standardization. And so responses to that item and the total score on that are not really valid anymore if you're giving additional instructions or directions or corrections to responses. Okay, so the last piece of what I would say takes test administration into assessment practice is how those results get integrated. So now we've got high quality data. We have some confidence that was delivered and administered in a way with fidelity to how it was validated. There was no factors in the environment of the testing or interpersonal factors that might have influenced it in a way that made that data unreliable or inaccurate. The utility of that score now rests on us as clinicians to make the most out of it. We could just take the score and say you're above or below the cutoff for a certain level of risk for a certain condition and be done with it. That's probably the most minimal thing. Some settings, that's all we need to do. In other settings, there's more things that can be done. And so really what I would push folks to do is to think critically about, okay, here's a cutoff score. Does this apply to my patient? What other information do I know about my patient? And would it change how much that cut score applies to my patient? And would it change the decisions I have to make about that patient's care? I'll give some examples here. Oops, we kind of got out of order here. Oops, we kind of got out of order here. I'm going to jump forward. I have some recommendations, but I'm going to give an example. So, sorry about this. Okay, just going to give just a quick little example here to illustrate these points about integration. So, just a prototypical, I see kids like this all day in my clinic. They come in, something bad happened to them, somebody died, they witnessed something awful, something awful happened to their family. This case is a 12-year-old girl. She had lost a grandparent who was a primary caregiver, and that parent died of cancer. It was expected, but she had been witness to lots of medical trauma over the course of his illness. And so it had been a little over a year since he had died, and she was still struggling with symptoms of grief, acting out at school, and having lots of behavioral problems and emotional difficulties. And so the remaining caregiver was wondering, okay, is this consistent with normative grief, or does she need help? Common referral question for us. And so we gave some a number of measures. I'm going to skip this. We can come back to this in a little bit more detail. But we gave a whole bunch of measures. What's interesting, we got 1, 2, 3, 4, 5 here. This took about 20 minutes to administer. These are all super brief. One is a measure of maladaptive grief symptoms. Another is a measure of PTSD symptoms. We got a depression measure, suicide measure, and then a measure of emotional suppression, which was part of a research study that she was involved in. If I were to talk through each of these factors with her and her caregiver, it would have taken me over an hour just to do that, and I would never have been able to get a history or any other important information from her. So right off the bat, what this allowed me to do is get her to give clinically useful, reliable, valid symptom information to me while I spoke with her caregiver to get background. And so kind of doing double duty. She's completing these while I'm working with the caregiver. And what we see here, I'm not going to get into the minutia of the data and the scores. Like I said, I got data. We can talk scores and data. But a big critical distinction in my practice is some level of distress after somebody dies, after you witness something terrible or awful, is normative, is normal. And there's going to be a period, we all remember our Psych 101, the stages of grief and that sort of thing. There's going to be a period where having some acting out, especially for children, having some emotional difficulties, that's normal. And so the first question for me is, okay, yes, they're reporting problems, but are these problems out of consistency with developmental norms? Are they at the level of clinical significance? And this type of testing allows you to do that in a way that, like you would do with biologics. Whereas it's not clear when you're just in conversation, are these atypical for a child? And the other thing that we try to distinguish is, especially in a case like this, is she was exposed to a lot of medical trauma, and there's also a grief element there. So are we dealing with persistent grief? Are we dealing with traumatization? Are we dealing with depression? Just run-of-the-mill depression or something else? And for those of you who are not familiar, the evidence-based treatments in psychology for those problems, each of those problems are different. So it's not like we could just give the same treatment and then hope all of those symptoms improve. So what this allowed me to do, this battery of assessments, is to pick out, okay, what are the most prominent symptom features for her, and then prioritize treatment decision making. And so for her, what I see here is, just to point out a couple of things, is her PTSD score and her maladaptive grief score were both above the clinical cutoffs that are provided by the test developers. So if I were to just do the psych testing approach, which is, okay, cut off, and then the decision is give her PTSD treatment and give her prolonged grief treatment, that would have been somewhat consistent with the data. What I did was something different. I looked at the symptom scores for the different clusters of symptoms, and I also took information that I knew from the patient about what was most impactful for her, what was she most motivated to work on, what the caregiver was most concerned about, and I used that to adjust those recommendations. So I knew that based on the scores here that suicidal ideation wasn't a big concern. It's not above a clinically significant cutoff. Normally, any sort of life-impairing or life-threatening behaviors, that's always going to be the priority. So that wasn't something that was going to be a priority for this case. And then when I looked at the individual symptoms of these two syndromes, what I noticed is a pattern. And so I'll point out a couple of things. So if you look at the PTSD reaction index, the two primary features of PTSD are re-experiencing what happened to you. So having thoughts and memories and feelings related to the event long after the event. Those thoughts and feelings and memories are unwanted, and they occur at times that are inappropriate, unexpected. So you could think about nightmares, flashbacks, or just having memories or feelings and intrusive thoughts at times that are unhelpful to be having them. That's primary feature number one. Primary feature number two is not wanting to be around anything that elicits those symptoms. So if you notice that going to the place like a hospital where the person died, hearing about things like COVID or medical trauma on the news, those upset you, so you stop watching TV, you start as a child refusing to go to your annual physical, you don't want to even go to the nurse's office. That's a primary feature of PTSD. And what we see for her is that she didn't report many of those. She didn't report, I mean, I was working in a hospital, she had no problem coming to the hospital. She had no problem with being around medical stimuli and reminders of the medical trauma of what happened to her grandfather. And if you look at the grief scale score, those subscale scores told me that she was really dealing with just really longing for and missing her grandfather, person who raised her, basically like a father to her. So even though she had high scores on the cutoff for both measures, she wasn't really responding in a way that was classic PTSD. A lot of her scores on the PTSD measure were elevated by the more general symptoms of PTSD. Negative changes in mood, some irritability, some angry outbursts, and those sorts of things. And because she didn't have those primary features, I decided to develop a treatment plan that focused on prolonged grief. And that's a really, in my mind, a pretty good example of how we can take the stock guidelines for using this data and integrate it with other information that the measure provides or information from patients or other sources to really come up with a more nuanced plan of care. I think right now is a good time to open up for some questions if anybody has any or comments. Go back here. Got some more structured recommendations here, but thoughts on that?
Hey, Cody, this is Catherine Cunningham. This is really great guidance. I appreciate you giving us a chance to hear your perspective. I don't know if this is the time to ask this question, but I'm curious if there are any strategy or guidance that you have on how to match a patient and a provider based upon their potential match. You made a very key point about interpersonal interactions between the psychologist and the patient and how critical that is. But it seems I'm not a clinician, but it seems that a lot of failed opportunities happen because of a parent or a patient, him or herself, don't know how to match that and don't know how to find the right person to begin with. I just wondered what your thoughts were.
That's a fantastic point. That point, the fact that the interpersonal characteristics, the rapport between the provider and the patient, the family, the child, the adult, affects all of the information that we give us. It affects the quality of our care. if that's one take home, that would be my solid only take home that I would give y'all today. With regard to matching, there's a couple of thoughts here. So scientific evidence is pretty limited and mixed on that point. We don't have a good algorithm or a good way for matching patients and providers. There's been tons of this with therapy and psychologists. There's some data on this with medical providers, but a ton of it with therapy providers because we visit with our patients more, we have more of a prolonged relationship. And the research has been done, has sort of ruled out, okay, do we need to have some sort of gender match? Do we need to have some sort of racial or ethnic match? Do they have to have similarity with cultural backgrounds? Does having an interpreter make a real big difference? Those sort of major sort of demographic factors of matching don't seem to improve patient outcomes in terms of quality of rapport or satisfaction with visits or even more downstream health effects. Beyond that, like finding a little bit more specific, like personality characteristics, there's not really a good data on a specific match. What we know is that providers who are highly agreeable and highly uncritical are good with everybody. So it's not that, at least from a group-based perspective, when we look at factors that predict patient satisfaction and indexes of rapport, it's not that maybe one certain personality style matches with one patient certain personality style. It's that a couple of things. All patients, doesn't matter if they're the nicest, most sweet, most agreeable and easy patients or the most curmudgeonly, gritty, difficult to work with or challenging patients. Everybody wants to believe that their provider understands them, sees them, recognizes their problems, and gives some validity to their problems, takes them seriously. Doesn't matter who. So that level of agreeableness and acceptance is probably the #1 predictor. And then the opposite, these two things kind of go. What we know from a lot of visits, from a lot of research with therapists, is that criticism and negativity from providers is a real strong indicator of basically everything that we just like. Dropout, patient dissatisfaction, patients not adhering to medical treatment or psychological treatment. So what I would say is that it's less about matching the patient and the provider. I think we as a field, mental health care providers, healthcare providers, and all the allied disciplines, if we want to improve our patient outcomes, we have to take responsibility for that relationship because the patients aren't going to do that. And we have to make in place interventions to increase the level of acceptance and decrease the level of criticality and negativity within our visits. That's really, from a research perspective, the most robust evidence that we have.
Great, thank you for that. I appreciate the complexity, but I feel like if there was some way that we could match people, I don't even know, better descriptors on a provider online, you know, something that actually gives you a sense of whether or not you're going to match with them, that would be helpful. Because right now, UTMB's website isn't particularly exciting in that regard. But
yeah, and so a couple things. I'm hopeful that someday we will have those factors. What I know is that if you think back to your Psychology 101, the big 5 personality factors, extroversion, introversion, those sorts of things, when they've done studies where they match patients and providers based on those broadband personality characteristics, and you don't find any differences in the matched versus the unmatched groups. So what that leaves us is that there's probably something a little bit more granular that it's just going to take a lot of research to figure out. To get back to the point about sort of negativity and criticism and acceptance in a patient-provider visit, I think for us as healthcare providers, it's very hard to do that because we do those things even if we're not registering them. Patients can interpret what we say as critical or as disregarding or as not accepting or as dismissive. Because we are asked to give recommendations, because we are considered a source of expertise, we try to fulfill that role. We try to be direct, we try to be explicit, we try to be assertive and to the point. If a patient needs to improve on something, we try to tell them that because we want to help them and they're coming there for that information ostensibly. But a lot of times, patients say they want advice, they want information, but nobody really wants to be criticized. What we know in psychology is most people operate on acceptance and being understood and appreciated by others. And even when they say that, no, give me the good, like give me the hard feedback, we know that they don't want that. And so it can be really hard when you're in this role where people are literally asking for your information. What can I do differently with my lifestyle or with my health care? That doesn't mean it's not going to be registered to them as dismissive, even if they ask for it, unfortunately.
Right, thank you.
Great comment.
Cody, I've got a question for you that I hope is relevant for a lot of the participants today. So you mentioned that there are some obvious circumstances in which we might want to take assessment data with a grain of salt or even discount it entirely. Like if the patient doesn't understand the questions, or if the assessment measure is delivered in an environment that's not conducive for giving forthright, honest answers. Like if you're asking a kid about substance abuse in front of the parents. Yeah. What do you feel, aside from like those really obvious things, do you feel that there are some clear situations in which clinicians need to watch out for that may make their data less valid and are common reasons why people give inaccurate answers?
Yeah, so a couple of things that I would say are pretty common modifications that people make that seem subtle, they seem like not a big deal. Reading the questions, we know from research, has a huge impact on responses. So what we know is that if you're going to be asking people something, especially if it's of a sensitive nature, they better have bought into your whole story. They better trust you. They better really want to hear your perspective on it, even if it's just an assessment only. It's not a back and forth, because they're going to respond to it that way. So what we know is that when you have providers who, let's say, have a long-standing relationship, like a pediatrician, and who has seen the patient for their whole lifetime, versus administrative staff who somebody has never met before, they're going to give different responses if those people are asking those questions. There's some good data to suggest that that relationship can be leveraged to get better information. So I could see why people want to do that. If you have a good relationship with somebody and you ask them questions, it opens up the opportunity for them to say, I don't know what that means. Common one on the PHQ kids always ask me, like, what the heck does restless mean? That's not a word in common parlance anymore. You know, the PHQ was developed in the 90s. Kids don't use that word, yet it's in there as a symptom. So if you're talking, it opens up the opportunity for that. But what I would say is probably the best way to do it is to try to make as minimal modifications as possible. So that's number one. Number two is the social environment, is just where they're administering the measures. Totally understandable. You want to get demographics, all the healthcare data, history data on a clipboard in the lobby. If there are other people there, don't do it. It's just not going to be. It's just not going to be reliable or valid. I'd rather you if you have to save that much time, I'd rather you find a measure that's even more brief that you can still administer back in the office than one that is administered that somebody fills out while somebody's looking at them or while they're sitting next to somebody. We know from the research that those two sort of areas of change to the standardization really make a difference in patient responses.
I appreciate that information. That's a really nice summary. I think it's helpful. So it sounds like what you're saying is a lot about your relationship with the, at least that was one factor you mentioned, that it's a lot about your relationship and your level of trust with the patient. So for instance, you could have a context where you're assessing for suicidality, and a patient, if they were given a written question of, do you ever have thoughts about killing yourself? They may say yes, sometimes. But then if that question was read to them by a provider who they don't really know, they don't really trust that well, they might say, oh, no, I never think anything like that. And so you're getting an error in which the problem is there, but you're not detecting it. Or on the flip side, you could have a person who is maybe very, very, very comfortable with their provider, who may say on a questionnaire, not really, I don't think I have those thoughts. But then the provider goes, I know you pretty well and you've struggled with those things in the past. Is that how you're feeling? And they might say, you know what? It kind of is something I do struggle with. Is that accurate?
And a good example of that would be if a patient says to me, not really, I would say, well, that's not one of the options. So do you mean sometimes, 2 or 3 days a week? And the moment that you're doing that, you're steering their responses, and whether it's well-intentioned or not. And you can do that not even leveraging that relationship or prior knowledge. You're just trying to help them fill it out. But it's different than if they were doing it alone and all they have is the paper or the iPad, and all they can say is, well, I don't feel like I really have those thoughts. I guess I'll put no. And what we know is that the predictive validity of that measure, the sensitivity of that measure, the scientific characteristics are based on the condition I just explained, not the one where the person goes, well, what do you mean by so there is a chance that sometimes you do it. That did not happen in the research on that. And the research where we make those manipulations subtly, it's not small differences. You can get wide differences in scores and responses when you do that. So it's not a small change. And just to add another kind of point on that is when we're doing that, when we're kind of going on our gut to try to help sort of juice or improve the quality of assessment. So my research, what we did is we allowed providers to ask follow-up questions about individual item responses. And what we were able to do is find out that patients or providers only followed up about specific items or specific scores. We could predict that based on the child's race, based on the child's age. So you don't want to be making, those are the types of subtle biases that creep in. If there's maybe a cultural difference or a background difference or a language difference where you're prompting more for kids with different backgrounds or adults with different backgrounds or disabilities. That can creep in without you knowing, and you're intending to do so to improve the fidelity of the measure. And really what you're doing is introducing a systematic bias across patients and within patients.
Sounds like you're saying that in a lot of ways, when we want clarification with an assessment measure, we are doing more harm than good by asking for clarification.
Yes, absolutely. And so I have some, David, I can give you these slides and you can, I try to put as many concrete tips as I can. And one of the tips I have in here, these recommendations, is it's okay to follow up. Just do it after the test. So that intuition is good. I'm not actually arguing for the rigid approach. The only rigidity I want to see is more rigidity with respect to how the measures are administered. You can use more flexibility with how they are interpreted. And one of the best ways to ensure that our data is robust, reliable, and valid is to ask follow-up questions to determine whether the boundary conditions of that test are met or not. You know, if I give a measure to somebody and I ask, okay, so what do you think recklessness means? You rated this super high, and they say, oh, it means like where like you're kind of sleepy a lot and like you can't pay attention. And I'm like, no, that doesn't mean anything to them. So, you know, I can adjust my confidence intervals on that score appropriately. I wouldn't want to do that within the measure, because then I might convince myself that they're giving reliable information when they're really not, as far as the test is concerned.
Awesome. Thank you for clarifying that. That makes it, that's useful information. With the notion that we only have a few minutes left, I'd love for any of the clinicians maybe to, anyone's got questions or a case example that they want to talk about.
I know that we got some classrooms here, so I was just going to ask, I don't know if there are people who are individuals in the chat, if anybody wants to throw out some of the common measures. Like I know we've talked about the PHQ quite a bit. Measures that get used, I'm just kind of curious, do people use measures other than the PHQ? Are people assessing suicide with some standardized measure? I know the general topic of this series is substance use. Like, what measures are folks using? If you just want to throw that in the chat. And if you're not using a standardized measure, you could throw in informal. Not everything I assess for, I use a questionnaire. I'm not the questionnaire guy. I use them when it's appropriate, when it meets those goals, when I need to save time, when I want to determine whether the behaviors or symptoms are clinically significant or developmentally inappropriate. There's plenty of things that you don't need to. You know, a pretty common example is bedwetting. You know, I ask a parent of a 3-year-old, does he wet the bed? She says yes. I'm like, okay, no big deal. If I ask a parent of an 18-year-old, does he wet the bed? She says yes. Okay, it's clinically significant. I don't need a test to tell me that. Okay.
Hi, this is Dr. Islam. Dr. Dodd, a great presentation.
Thank you.
Clinicians latch on to numbers. Hello, just a sec. Yes.
You hooked me with that stem of a question.
Yeah, clinicians do love numbers.
They do.
Yes. It sounds like he may be going in the direction of, you know, how much confidence do we place in, you know, cutoffs and.
I'm sorry, Dr. Dodd.
Sure, go ahead, Dr. Islam.
I was talking about clinicians' thought process and mindset. We love numbers. So I have seen PHQ-9, you know, and we are always rushing. And we look at numbers. We look at lab numbers. Screening numbers are very, very difficult to interpret, and you laid down the groundwork of not just looking at that number. Have I seen a number which says PHQ-9 8? And when I look at the bottom and it says, I'm suicidal every day? Yes, I have seen those. So you made a big, great point. Number does not really matter. It's the whole person you talk to. And you have to have those clinical sort of nuances and say, this doesn't look like real depression. You know, it is beyond just depression. So I think so we have to be very, very careful picking up a number from all these screening tools and say, you made that cutoff point, so you are this or that. So I'm glad that you sort of talked about the whole issue of clinical, judgment and the numbers in screening tools. We have to be very careful about that. And giving those questionnaires, I have seen being shoved in the room without being explained to the patient what the questionnaire is about, how to administer it. Is it 2 weeks? Is it a month? Is it lifetime? Those we have to be very careful to explain the patient and help them interpret those questionnaire. That's all I have to say. Thank you.
Great points. I think you're pointing out sort of like what I would call like a doubling down of a problem. So we have poor, oftentimes because of time constraints, poor administration characteristics. So we're getting garbage into the system. Then the results that come out are not great. And then because of time constraints again, we're doing little critical thinking and integration of that data. So we're either disregarding it 100% or relying on it and not considering its boundary conditions, its reliability and validity. And in most of those cases, it's not super useful. It just really is not, and it doesn't need to be time consuming. I think we can kind of strive towards improving towards these more of an assessment-based approach rather than just a testing-focused approach, wherever you're at, whatever your time constraints are. I think if you just start by asking yourself, if you're a score-based person, I love scores. I'm in research, I use data all the time. If you just get in the habit of asking yourself, okay, number one, do these data comport with the other things I know about this patient? If not, why not? And number two, do I feel strongly, after thinking about the conditions of this testing, do I feel strongly that these data are good data? Again, if I go back to, if you have somebody do labs after they run a marathon, or after they were in a car accident, and or while they're having a panic attack, or while they're having a heart attack, you're going to get a different set of results, and maybe you're doing that on purpose, but you better be doing it on purpose. It shouldn't be something that you didn't know that they were having a heart attack while those labs were being done, or they were running a marathon right before it. Otherwise, you're making your decision making based on data that's just unreliable. So, great points, and I think or getting stuff on the scores can be really tough because it makes things easy. So it's a hard habit to give up because it makes things real simple.
Great. Well, with that, I think we're going to wrap things up. I want to thank Dr. Dodd. That was a fantastic, really well thought out and delivered presentation that really gave us a lot of insight into the way we think about assessment, the way we use assessment in the clinic, and really gives us a lot more things in the future to talk about in terms of specific assessment strategies. So we're really just getting out of the gate here with what we can do in this domain. I want to thank everyone for participating today.